Up next is Dr. Dileep Ramen, intensivist and co-founder of Cloudphysician. Most of us are new entrants to virtual medicine, but Dileep and his company have been delivering high-tech, high-acuity care remotely for 5 years now. Dileep, could you please start your presentation on and give us an idea of how Cloudphysician works?
Yeah, hi. Good evening, everybody. I hope my slides are visible. This is Dileep here. I am an ICU and a lung specialist. I did my MBBS in India and then went on to do my fellowships in pulmonary and critical care at the Cleveland Clinic in the US. Being there for some time, we were closely involved in how a tertiary organization was looking to leverage its group of ICU doctors to cover a diverse set of ICU beds across a large nation. And they were facing similar challenges in how to ration ICU doctors and cover large number of beds with resource constraints with respect to ICU service delivery and ICU skills. And that parallel was nearly identical in India, but to a much, much larger degree. The deficit between trained ICU doctors and the requirement in India is pretty substantial. And as we all know in the West, that an intensive care unit should be run by an ICU specialist, also known as an intensivist, because that is what optimally improves the outcomes and survival of critically ill patients. The problem statement in India is much wider. So having realized that, we sort of wanted to come back to India and see if this Tele-ICU model or the high acuity version of telemedicine was feasible and how it could be implemented in a resource constrained settings with all the diverse challenges that are there in the Indian ecosystem. So from a definition perspective, for an intensivist, this is, I'm laying this up in front of you because we need to understand that probably about 1 in 10 patients in the ICU in India, 1 in 10 patients have access to an intensivist. So that's like 90% of Indian ICU patients do not get to see a fully trained intensivist during the course of their ICU stay. And to crystallize that thought further, it's important to understand that the healthcare ecosystem is faced with an iron triangle. And this iron triangle has 3 vertices that denote quality, cost, and access. And for this iron triangle to be broken so that you can actually give distributive access and high quality at a reasonable cost, you can give service, there are only very few tools that can achieve that at scale, and technology happens to be one of them. For instance, it's hard to give high quality critical care at low cost to a population the size of India. And really the problem statement was ripe to be solved. And that's where we thought that a rediscovery and a reapplication of tele-ICUs as they are in North America needs to be understood, broken down, and reassembled in a way that it will actually be useful for the Indian setting. I know there's a subsequent discussion on telemedicine guidelines and how they work, but from a tele-ICU perspective, what is relevant is that we are in a model that actually empowers the doctor. So in the sense, it is a registered medical practitioner augmenting another registered medical practitioner who then in turn helps the patient. So a typical tele-ICU, a telemedicine model that the speaker before me, doctor, was explaining was a doctor to patient through a screen model, which is RMP to a patient. In the tele-ICU space, in the high acuity space, you always need a doctor at bedside. So tele-ICUs do not replace bedside doctors, they augment them. And that is the model that we utilize in India and many parts of the world as well to run and operate a tele-ICU. How we do it at Cloudphysician is we take a computer vision based approach because of various challenges in India that involve devices not being connected to a central server or makes of these monitors being unsupported by technologies and them not being interoperable, had sort of forced us to look at a solution that relies on cameras and a computer vision based technology that allows us to deploy and put our cameras there with our own firmware that talks to our platform, allowing our doctors and nurses stationed in Bangalore, which is a city in South India, to connect to ICUs across the country. And the setup and the way that we are able to impart care is a very asset light model. So you could probably describe it like an ICU or a tele-ICU in a box, because the models that are prevalent in the West are very resource intensive. They're very expensive. They require a very strong foundation on the part of the hospital to have an information technology stack so that you can build the tele-ICU platform on top of it. That is not the problem statement in India. In India, you have to start from scratch. Some of the hospitals are on paper. They don't have an electronic record system. So we had to work with them and design a platform built for the Indian context that can run on a mobile app, can run on a PC or a tablet, and can be run by a nurse who may not have the same expertise as a critical care nurse that you would find in a metro city or even in the US, for example. So just to give you an idea about how these systems work, these are images from our ICU in Bihar, which is a city called Motihari in Bihar. Actually, it's a township which is fairly remote, but we're able to see pristine images and videos of these ICUs in remote areas. This is just 90 kilometers from the Nepal border. And using our computer vision technology, we can actually parse this data and auto-populate the platform that allows us to digitize the patient record at this remote facility and allows our doctors and nurses in real time to support the bedside team to allow them to take better care of their patients. And these are images that also allow our doctors to help the patient's families. So, for example, a common question asked in India is that how are the patients going to respond to telemedicine and tele-ICU? And tele-ICU is obviously a lot more acute. The patients are sicker, so the emotions run high. And what we have found is pleasantly to our surprise that patients and their family members just want to have someone to talk to. And as long as they have access to a well-trained doctor and a well-trained nurse and a team, the bedside and us with a three-way conference with the patient's family are frequently able to allay their fears and actually enable them and us to deliver better care to their loved ones, which is really why we're all here in the first place. To give you just a brief idea what a day in the tele-ICU looks like, you have the bedside team on one hand, reviewing the patient, looking at the patient's data and sharing some of that data on the app. Some of the data is directly integrated into the platform and we can review the patient remotely from our screens here in Bangalore. All the documentation happens on a centralized platform. It could be any platform, it doesn't matter. And then the collaborative care starts where the doctor and the bedside doctor interact, discuss about the patient. The data is available on the go on their app so that they can do this during the busy part of the day when they're moving to the hospital. And then we have time for a collaborative approach where all the teammates and team members can get together and help in the care of the patient. So we're trying to do it as best as we can in a resource constrained setting. But the other important thing is that we do have access to India-specific data, which we can bake into our analytics engine and then go back to the clinician and support them with a clinical decision support system. Now, early in the days, when this is being rolled out, the support system is obviously based on real-world doctors and nurses talking to them. However, little by little, as the system matures, we're able to automate a lot of this. And some of this is already happening where the data would speak for itself and assist the bedside team in the day-to-day care of the patient. The key point here is that if telemedicine really has to have a global impact, it cannot be designed with the resource-rich states or the places where the technology is easier to penetrate. You need to drop the barrier so that the people who actually need the service can get the service. So our motto here is to frugally innovate as much as we can to lower the barrier so that these services can be adopted. They then become scalable because of their utility and optimize the care of the patients at scale precisely where they are needed. And you end up optimizing their outcomes and indeed saving lives in many cases. So to give you an example, even larger centers in India can actually leverage the strength of their intensivists to ration patients, because during COVID, we frequently saw that a COVID ward would be inundated with patients with varying levels of severity. So sometimes if you intelligently design your system, you could have an ICU doctor take care of 50 to 60 high dependency patients who are not on a ventilator without sacrificing their ability to take care of a critically ill ventilator patient. And that is exactly where a virtualized network comes in. You need to segregate and ration your resources so that these scarce resources are best deployed. For instance, India just has about 4,800 trained intensive care specialists. That is woefully low for 300,000 ICU beds that are projected to go live by the end of this year. And we're talking to governments where different state governments in India where they want to scale up the ICU infrastructure. But the problem statement is always going to be where the rubber hits the road. And that is, you can buy 100 ventilators and set up 100 ICU beds. How do you provide service to them? Now, the ideal use case would be to have the doctors at bedside, but clearly the training programs in India are going to take 25 to 30 years to catch up to that need. And the next best step is to actually leverage technology so that you can get this 360-degree view of the patient, utilize technologies that we have for digitization, that use machine learning tools and enable the bedside to go up and running with a plug and play model so that their critical care needs can be met at scale. These are some of the examples of things that we've already done pre-COVID and during our COVID deployments, where we've taken care of thousands of patients in that realm, where right now we've seen more than 20,000 patient bed days overall and about 4,000 COVID specific ICU patients, not ward. This is ICU alone. We're focused on the ICU. So to not belabor the point, some of these things get asked very frequently when I discuss technology and related aspects, not just in the ICU space, but also at large. Bedside manner needs to transition to website manner. And the cornerstone for that is effective communication. Training programs in India need to focus on the interpersonal aspect of healthcare, because that is what was neglected in India. And that is now coming to the forefront, because when you're faced with a screen, you've actually put a barrier there. So if your baseline interpersonal and communication skills are not good, it's going to be very hard for you to succeed as a telemedicine provider. So technology should be working in the background, and the clinician should be at the forefront, where less intrusive technology is more integrated into their workflow, because there are a few things that technology may not be able to replace, and that is the interpersonal aspect of healthcare. And if technology does all the heavy lifting in the background, that can really bring to the forefront the human aspect, which is sorely lacking. So to cut to the chase, tech will not replace healthcare providers. But over the next few years, healthcare providers who use technology will certainly and unequivocally replace those who do not. And that is something that we are very keen on looking as we go towards this space of not just tele-ICUs, but virtualizing an entire care paradigm. And this is becoming more and more evident. And COVID has just acted as a time machine. It's taken us in this time machine and zipped us past 5 years and 10 years into the future, where we really need to take stock of this, use the available tools that we have, and go towards a brighter future in healthcare, not just in the developing world, but also in the across the globe overall. So thanks for this opportunity. I'll conclude here and hopefully allow the discussion to proceed so that we can take up some interesting questions. Thank you.
Dileep, I'm sure everyone's waiting to ask you a lot of questions, but I'm going to ask everyone to be a little patient so that we can do the Q&A session towards the end.